guys have questions, don't hesitate to pop a hand up or blurt out your answer, and we'll stop and have a conversation about a slide. So I'm going to move into diagnosing lameness originating from the tarsus and proximal metatarsus. And I think about these as a region because the overlapping clinical signs. So as we go through this, I'm going to have some presenting complaints, a little bit of a review of diagnostic anesthesia, and then I'm going to go into the tarsus and some abnormalities in the tarsus that we're starting to find a little bit more, and then the proximal metatarsus and my approach to diagnosing problems in the metatarsus. As I think about the case presentation, this is just kind of a list of the proximal metatarsus versus the tarsus and the presenting complaints. And as we look at them, there's a lot of overlapping areas of problems. So lameness or poor performance, unilateral, bilateral presentation, flexion positive, variable response to palpation in the tarsus, variable response to palpation in the proximal metatarsus, and then is there a conformational issue associated with these proximal metatarsus? I think the previous conversations we've had in here, we really look at that a fair amount more. As I look at how we're potentially going to localize our lameness, I don't think anybody probably has a problem with the techniques looking at diagnosing putting needles into the tarsus and trying to find these things. So the tarsal metatarsal joint is probably the easiest, right? We palpate that little groove between the long plantar ligament and the collateral ligament, and then we stick our needle into that area. And it's probably one of our easiest ones to stick in there. And 3 to 5 mils is what's been published, probably a little bit less than that most of the time. The harder one probably is the distal intertarsal joint, and some of the techniques that have been described, and the palpate the T-gap between the fused first and second and the third and central tarsal bones and stick our contrast in there, or stick our diagnostic anesthesia in there, or there's this dorsolateral approach which has been described, and I think is becoming more popular for a variety of reasons. Seabaugh in 2015 did a study and showed that we're not so good at sticking needles into the distal intertarsal joint. So less than 50% of the time we're actually in the distal intertarsal joint, and with experienced and non-experienced people, it's trying to stick the needle in there. And oftentimes it's in this kind of subcutaneous space along the medial aspect of the joint. And even though it flows fairly readily, this is where it tends to deposit, and that's potentially in the cunium bursa. So when we're trying to block those, it's something to realize. And then there's always the communication. So this needle is obviously in the TMT joint, and we can see contrast in both the dorsal recesses of the distal intertarsal and the tarsal metatarsal joint, and that happens. If you read the literature, that can happen to 8 to 23% of the time, just depending on how hard you push in there. As we think about the regional nerve supply to this area, the tibial nerve comes through, goes through the tarsal canal, and then branches, and we have our medial and lateral plantar nerves, and the lateral gives off a deep branch to our metatarsal. And this is the one we kind of key in on and looking at blocking the proximal metatarsus. I think Dr. Redding is, not too long ago, we had a conversation about that too, and I think that you have to be really careful and move your blocks from distal to proximal. You can't just jump to this one, because there's no doubt you're blocking most of the other nerves up there. And this is a dissection that I had done looking at, here's the medial branch, here's the lateral branch. You can see the branch coming right here, and they're right on top of each other. And this is a new methylene blue study that I had done. And you can see the nerve coming down through the tarsal canal. You can see the branch coming down. You can see the new methylene blue is just about everywhere, right? And so, again, you just have to be cognizant not to jump to that block, because you're most certainly blocking the other structures in that area. In 2013, Kevin Claunch presented this at AEP about doing a deep branch study and used 3 and 5 mils of injectate, and the higher volume of injectate seemed like it was more likely to be in a TMT joint or have a proximal diffusion. We can see proximal diffusion all the way up here in this study with a higher injectate volume. So the 3 mils inch needle coming along the lateral aspect of the splint bone seemed to be the better idea. And so as we look at this a little bit closer, just in the overlapping overlapping blocking patterns. If we look at this study, this is a contrast CT that I had done sticking contrast within the tarsal metatarsal joint, and we can actually see the contrast come out, and some of this is extravasated for sure, but some of this contrast comes out and bathes around some of the lateral plantar nerve, and then we can see on this DP image, we can see this recess right here, and this is a part of the study that Dr. Seabaugh did. We can see this recess of contrast coming down into the plantar aspect, the medial aspect of the proximal metatarsus. So we can kind of get a feeling of why we would have these overlapping blocking patterns with intra-articular versus also our regional anesthesia of the nerve. And so a careful kind of study of these is needed. The other thing we have to be cognizant of mepivacaine or carbocaine is a lipid soluble, and it has a rapid onset of action. That also means that it's a small weight, a small molecular weight, and can diffuse between our synovial structures fairly readily. Go in 2002 did a study looking at where this, if you stick it in one joint, is it in another joint, and is it in diagnostic concentration, or is it potentially in a diagnostic concentration? It does readily diffuse between joints. I don't know that the necessarily proved in its entirety that this is at a therapeutic dose. So is it going to desensitize the area or not with mepivacaine? But nonetheless, we have to think about those kind of things when we're going through. So as we think about kind of our pitfall summary, our TMT injection can be surround our plantar nerves, our tarsal, and can be potentially in the region of the tarsal sheath. Our distal intertarsal joint, our distal tarsal joints anyway, we might not necessarily be in the joint we think we're in. Our subtarsal injection, we have the potential to be in our other joints as well. And most definitely we're blocking most of the regional nerves in that area, these aren't lasers, we're not blocking just one nerve. And the other thing to think about it is the time for which you do these. And Schumacher, as all things, they kind of think up of a lot of things about the blocking pattern, but Schumacher has a great summary of things to think about when you're going through your blocking patterns, time, what that means, where it's diffusing, right? So I think it's a nice review to go back and take a look at. So when you're out about 30 minutes, I don't think you can rely on that block anymore to identify exactly where you're at. So being a little bit negative on that, but I still think that is really the only way to accurately localize a lesion with some confidence. I think it's still the gold standard, and I think that is what Go and Baxter have also reported. It's still our gold standard to localize where our lesions are at in addition to a good physical exam. So I'm going to start with the tarsus, and our routine radiographic projections and our DLPMO, our DLPMO, our DMPLO, our DP, and our straight lateral. A couple of things that I look for a well-positioned DMPLO is I like to split the nose, the lateral trochlear ridge with the medial trochlear ridge, and then have my joint spaces fairly well. I think Dr. Puchowski yesterday did a fantastic job of going over how to obtain these and what to look for. So I'm not going to spend a lot of time on that, except for one area, which is the DP. The DP, this is a straight DP, and we notice that our medial malleolus is kind of superimposed over our talus, and so I tend to take this a little bit more in some of our survey radiographs of a 10-degree DLPMO, and that highlights my medial trochlear. And those of you that are in racetrack practice, probably that's what your go-to for your DP images anyways. And some add-ons that we do when we suspect some pathologic change, especially in the subsyntacculum tali or the calcaneus, is the skyline image. A lot of people take it if we're suspecting some injury to this joint here. I'll come back to that. Really, that's a kind of a low yield image for me to look at that area. And then our flex lateral, straight lateral, to look at the plantar or proximal aspect of the talus, looking for fragmentation in this area. This horse actually has a really cool lesion, this elongation or this mineral that extends along the succentacula tali. When I see that, almost always the deep digital flexor tendon is injured. They'll have some moderate to marked theropin. There's always variations in the tarsus, and one of those is the fused first and second tarsal bone. And when you see it, they're fairly few and far between, but when you see it, you'll catch your eye. And this horse has a fused first and second on one, fused first and second, and then another horse has a separate first and then second tarsal bone. So that's not a fracture with nice round margins. That's just a normal variant. So just realize that does occur. As we look at the central tarsal bone specifically, one of the biggest things that I look at is this nice cortical-medullary definition. And so this is subchondral bone, this is trabecular bone, and I like to see this extend all the way out to the dorsal aspect in a somewhat a naive horse. When they start to work a little bit, they'll have a normal adaptive response to that area. And Branch did a really nice job of reviewing that area in 2005 and 2007, and we can see this is a dorsal plane T1 weighted image, and we can see the nice dark areas are subchondral bone, the white areas are trabecular bone with some fat in it, and we can see this nice distinction between the two. When we start to put these horses into some work, this will become a little bit a thicker subchondral bone plate. Usually comes in along the medial aspect of this joint, medial and dorsal. So as these horses come into work, we'll start to lose this just a little bit along the dorsal aspect. And those Western performance horses, I see that a fair amount, especially the ones that are working hard, they'll start to lose that dorsal aspect. But this is also one of those continuum areas where when we have this normal adaptive response, at times it can move into a non-adaptive response, and that can be pathologic in its nature. So this is an 8-year-old warm blood jumper that had been blocked to the tarsal region. This is its radiographs. We can start to see we're losing that dorsal aspect of the cortical-medullary definition, and this is a dorsal T1 weighted image. This is a fat-suppressed image. And we can see that there's marked sclerosis along the medial aspect of this joint, or along this central tarsal bone. And then centrally located, we have this region of increased signal with a subcondylar bone defect, articular defect, right? So we have some medullary cavity change, so bone marrow lesion, so to speak. That can be a variety of things, not just edema, but that can be abnormal trabeculation, hemorrhage, necrosis. All of those things can be in there. It's not just an edema kind of lesion, but for the purposes of the rest of the talk, if I see something high signal in the bone, I'll just call it an edema-like signal. So this is a edema within there. This horse ultimately was injected into the tibiotarsal joint with some IRAP, and the horse went back to work over some time after some rest to try to reduce the medullary sclerosis. The medullary sclerosis, at least in humans, as we look back, has been known to cause lameness in humans, discomfort in humans just in itself by increasing the medullary pressure. And we have this similar supposition within horses in the foot where they'll have sclerosis within the palmar processes, and that can cause some lameness too. Ultimately, they'll tend to cycle a little bit because of the bone compliance, and those will fracture out. So chronic lameness can be associated with just medullary sclerosis. And then Daniels in 2012 in a JAMA article had a review of these kind of a case study of these, and most of these tend to be along the dorsal medial aspect of the joint, some injuries to this area as well. So as we look at the central tarsal bone a little bit further, as we look at this area again, horses that present for lameness and the radiographs just aren't making sense. Sometimes we need to move into something a little bit more, and the more we know about what's happening in some of these horses, the more we key in on the radiographs for subtleties to make us move into that next phase of imaging to look for or take special views to identify what we would consider or what we consider as a potential differential diagnosis of why this horse is lame. This is a 4-year-old quarter horse presented for a very strong 3 out of 5 lameness under all circumstances. As I look at these radiographs, there's not any sort of signs of arthritis in In the distal tarsal joints, the tibiotarsal joint is fairly clean. Not a lot of effusion. I think that's going to be interesting to note here in a second. As we look here, though, we start to lose the dorsal aspect of the cortical-trabecular bone definition. And when I think about that, the dorsal third kind of is when that normal adaptive response area, as it starts to move into the middle half, I think that is in a non-adaptive response. And when a horse is lame, and especially a strong lameness, I'm thinking about a couple of things. One, a subchondral cyst that I can't see and is causing a problem. Or two is a fracture. Or three, there's nothing else besides very severe subchondral bone sclerosis, and that in itself is causing some lameness. Or there's a subchondral bone edema-like lesion. So when I'm looking at this area, I have a supposition that one of those things are happening, and I want to explore that further in looking at these areas. This horse ultimately blocked or was isolated to the distal tarsal region, and went to MRI. And so when we look at this particular study, there's low signal here, which is sclerosis within the central tarsal bone, and then we have the cortical bone, and then this is our trabecular bone. And as we look into this area of sclerosis, we see this white line bordered by this kind of intermediate signal on this particular sequence, which is going to be a fluid type. And this area is sclerosis. We follow this coming down, and this is centered at the central tarsal bone, and that is a fracture through the central tarsal bone. And this is a concurrent stir image, so a fat suppressed image, which is going to highlight our fluid within our bone, so some edema surrounding this fracture line in the central tarsal bone. And that is a very common configuration, probably the most common configuration of fractures within the central tarsal bone. There's been a review of both racing horses and non-racing horses, and this tend to be how they will extend through the tarsal bone. They'll propagate usually dorsally, and I've had a fair number of horses that have come into MRI for a low-grade chronic lameness, and they'll have a start of an insufficiency fracture along this dorsal aspect, and then ultimately at some point this will cycle and they'll fracture through. But along this dorsal medial to plantar lateral fashion is how they tend to be. And so if we think about that, and we're wondering, because we tend not to see those just on our conventional images, if we start to think about that fracture configuration, and we start to walk our X-ray generator around the tarsus, this is our straight DP. Now we're coming a little bit more towards the medial aspect, so this is about 10 degrees. We start to see this nice line right here, and this is 20 degrees. Looking at this, and we have this nice fracture line extending through the central tarsal bone. Not all of these, right? This is a biarticular fracture, but not all of these will present with effusion within, especially in their acute stage, effusion within our tibial tarsal joint. So if we're suspecting something, a very strong lameness, and it is isolating to our distal tarsal joints very nicely, this is to just walk around and prove yourself there's not a fracture. So then we move on to our next phase of imaging. That may be bone scan, that may be MRI, that may be CT, all of those things potentially to identify extra things that are happening within this tarsus. Because the more we're doing our advanced imaging, relating that back to our radiographs, we're getting better at reading radiographs for sure. So it's always good to have that advanced imaging and then go back and look at our radiographs and see if we can find those lesions and prove it to ourselves. So moving into the talocalcaneal joint, this is I think not necessarily a common place for degenerative changes, but it's considered significant all the time when we see that there. And so when we look at our lateral radiographs, this is probably our best view to look at this area on. We can see this is the medial aspect of the joint, and this line coming down is the medial aspect of our talocalcaneal joint. Our lateral sits up here, right? This is our lateral, this is our medial, this is sustentaculum tali. And as we follow that down, it has a very nice bone margin coming all the way down, very nice and smooth as we look at that area, and we'll kind of go into that a little bit here in a second. As we look at this horse, this is a 10-year-old thoroughbred that presented for lameness, and it blocked to a deep branch of the lateral branch of the plantar nerve, very, very nicely. And as we look at this, there's osteoarthritis in our distal intertarsal joint, mild osteoarthritis in our tarsal metatarsal joint, but we have this marked osteoarthritis in the more distal aspect of our talocalcaneal joint. And this is a little bit of those things of satisfaction search. It took the tarsal radiographs. A lot of people tend to focus a little bit more on our dorsal aspect of, because that's where common things occur, right? Common things occur commonly. We're looking for areas of osteoarthritis along this dorsal lateral, dorsal medial aspect, and our eyes are trained to go there. And so this horse has this moderate osteoarthritis in distal intertarsal joint. They send him to us, we take a look at it, and there's this marked osteoarthritis, and then this is always significant, right? If we think about the literature, a case series of 18 horses, the prognosis for these guys going back to work isn't always that great. So only 50% actually go back to work in some manner, usually at a very low level. Looking at the talocalcaneal joint, oftentimes we have chronic limb lameness will come in for a bone scan because they're not well isolated, they're challenging at times, and the previous radiographs haven't yielded any answers. So as we look at this particular area, this is a horse, we have this marked gluteal atrophy along the right side here, and normal gluteal musculature on the left side. Bone scan, as we look at this areas, nice uniform area of radiotracer in the distal aspect of the left, very similar on the right, and then we see this kind of linear uptake along the distal caudal aspect or distal plantar aspect of the tarsus, and that is all medial on this caudal image right here. And so this horse had radiographs coming in, and as we look at this, had radiographs that we had taken after the bone scan, if we look at this area, and we just had this area, these are very subtle changes in this particular horse, and that can be, right, if we look at that very quickly, that can be overlooked very easily, right? But as we look at this, there's a nice area of subchondral bone lysis. This is the corresponding limb over here. We can do a fusion study. Those of you that use the best operating system in computers called Max, you can actually do this. You Windows people are SOL. But as we look at this area, we can fuse these nuclear scintigraphy studies very nicely, and I do that very, very frequently. So if I have a nuke study, I'll fuse it with the radiographs afterwards, and that makes me look at areas much more critically and identifying areas of abnormal radiotracer, and then the corresponding radiographic change. And subtle things in horses, small things in a big animal cause lameness. That's no doubt. And so this is a very subtle amount of radiotracer that's coming down here, and a very small amount of bone change. But this horse, as you can tell, was chronically lame. We blocked this horse and resolved with a tibiotarsal joint block very nicely. As we look at the distal intertarsal and the tarsal metatarsal joints, these are our most common areas that we're going to look for abnormalities, so osteoarthritis in this area. Hopefully going to go over some things that I tend to look at a little bit more frequently just because of the amount of MRIs and nuclear scintigraphy studies that I get to see. We all see this kind of this irregular bony proliferation along the inside of the leg and have a supposition that there's going to be osteoarthritis in our distal tarsal joints. This is, in some papers we'll look at, this is one of the more common areas. If you're an Icelandic pony, it's dorsolaterally where the osteoarthritis is. I tend to think just along the dorsal medial and dorsal lateral aspects of the tarsus are where we're going to see our osteoarthritis changes. Not all of these things are significant though, and I think we know that over time and clinical experience, but also some of the literature, and not all of them are associated with a degenerative change within the joint. Some of these can be associated with some of our ligaments around them. So as we look along the dorsal aspect, we have the fibularis tertius or peroneus tertius, our craniotibial, and our dorsal tarsal ligament. And this little bit of bone proliferation can be an enthesophyte associated with any one of those, and not associated with lameness. So this typically is not a significant thing as long as it has a fairly uniform opacity and the joint around it is fairly normal. So usually not a big deal. Comment on it, usually not that big a deal. But as we think about the plantar aspect, and I think this is one of those areas that kind of goes kind of unsaid or unlooked at a lot of the times, and it's because it's oftentimes a little bit more challenging to look at this area because of differences in radiographic positioning and technique. It can be a challenge to look at it. This is a 7-year-old gelding, and this is a horse that I had at the beginning of my residency to start to think about this a little bit more. 7-year-old gelding, presented for lameness, had radiographs. We didn't see much on radiographs, so I remember reading these. I'm like, oh, there's not much here. Went to MRI, and this is a sagittal plane image centered around this joint right here. So this is the fused first and second. Fused first and second. This is our third tarsal bone, central tarsal bone here. This is a dorsal plane image, our central tarsal bone, our fourth tarsal bone here, and then this is our second sitting right here. This is the very plantar aspect of our third tarsal bone. And we can see this marked low signal surrounding this area, and then the irregular joint margin here, and there's marked sclerosis. This is really the only thing we could find on this horse, and there was some concurrent fluid signal within the bone. This horse, then we went back and blocked in the tarsal, metatarsal, and distal tarsal, blocked very nicely. This is the area that was the cause of this horse's problem. Treated the horse, gave it some rest to try to resolve some of this bone sclerosis. Again, degeneration as well as the bone sclerosis can be a cause of problem for lameness in the horse. So started me thinking a little bit more about the plantar aspect of the joint, as well as looking at some of our nuclear scintigraphy studies as well. So this is a horse that presented, a 9-year-old warm blood gelding that presented for a pre-purchase exam, was 2 out of 5, left hind limb lame, severe response to flexion, right hind was fairly mild in its response to flexion. As we start to look and compare these two side by side, we have a nice joint margin right here, looking at the tarsal metatarsal joint. This joint between our fourth tarsal bone and our fourth metatarsal bone, third metatarsal bone is nice, has a nice cortical trabecular bone definition. Now as we look at this left hind here, we have this marked sclerosis extending down into the plantar aspect, and then all the joint margin is narrowed along its more plantar aspect, and even dorsally too, but majority of the osteoarthritis or degenerative changes along this plantar aspect. Of course, ultimately, because of its lame and had radiographs that had a fair amount of degeneration, was passed on. But again, looking at this more plantar aspect, I think is important. And I'm going to circle back around a little bit to that plantar aspect to try to summarize some of this a little bit later. Nuclear scintigraphy is very helpful for that, especially for subtle changes. And again, I tend to look at these areas and try to fuse them a little bit. I didn't do it in this study, but if I compare these one side to another, there's this abnormal radiotracer that extends a little bit more plantar comparatively to our left, right? And so as I take these radiographs, I think the radiographs can be a bit of a challenge. So subtle changes in obliquity can narrow our joint. I think these radiographs are fairly well paired in terms of their positioning. And if I look at this joint margin coming back along the plantar aspect, on the left side it's very smooth. I start to lose that joint space back here and have a focal area of lysis along the plantar aspect of this joint. We blocked this horse, resolved its lameness from the distal intertarsal joint, and gave it a little bit of time of rest and rehabilitation, and then injected it with corticosteroids to move it through, and did fairly well. But this more plantar aspect, in some of the literature you read, there's a supposition that this may be a more significant injury than the dorsal aspect. And I'm going to summarize a study at the end that we did looking at MRI in the Tarsus and Proximal Metatarsus. But one of these areas to start to consider and look at a little bit more critically, as long as we have well-positioned radiographs, is this more plantar aspect, because they can have plantar aspect osteoarthritis with not really much along the dorsal aspect. If we think about the distal intertarsal joints and tarsal metatarsal joints and go back and look at our surveillance studies, and I think those are best to get a distribution of what's happening in these and kind of get an understanding of what we know about the osteoarthritis in the distal intertarsal joint and tarsal metatarsal joint. In this study, there's over 3,000 warm bloods. 7.2% failed to possess radiographic indicators of distal intertarsal joint osteoarthritis. 7.2%. So almost all of them had osteoarthritis in the distal tarsal joints in this review. Now that's a little bit converse to young thoroughbreds coming through the sale that Kane did in 2003. Only 14% of these horses had signs of radiographic osteoarthritis. So there might be a disparity between some of our warm bloods and our thoroughbreds and what they're going to do. Again, this was a larger number for sure, so that power is going to be a little bit better. What we can say about osteoarthritis in the distal intertarsal joints is the degree and duration of lameness didn't correlate with our radiographic findings. And that was a Byam and Cook paper in 2009. And then horses with a little bit conversely, horses with enthesophyte and osteophytes of our distal intertarsal joint and tarsal metatarsal joint had a 5 times odd ratio of being lame. So the severity doesn't always correlate the duration, but if we have some osteophytes, we have a little bit greater indication that they're going to become lame or going to be lame in that area. So our severity doesn't correlate, but at least having the presence of that area may give the odds that they are going to be lame in some respect in that area. Another area to think about is our our intertarsal ligaments. And so there's several of them as we move through our tarsus, right? We have a ligament between our central and third tarsal bone and our central and third metatarsal bone. There's a large ligament between our calcaneus and our talus. But one of the ones that I see the most frequently injured in this syndesmopathic injury is this ligament right here. And as we notice, this is a normal ligament in a normal space. We see this nice thin rim of cortical bone surrounding this area. We see that here too. Nice striation of the ligament on the sagittal plane MRI. So what are the things we're going to look for in syndesmopathic injury? This is a 7-year-old, warm blood, flexes positive to flexion. Not really all that lame, more of a performance issue. But if we look at the normal on this DLPMO, we see this nice rim here. Here we start to see sclerosis that surrounds it. It's filled in with bone. And the more plantar aspect of this distal intertarsal joint is mildly narrowed and sclerotic as well. So we have osteoarthritis, and this is a common, we see osteoarthritis in combination with this syndesmopathic injury. And so we look at this area fairly critically now, and this is the corresponding DP. We see it's filled in with bone, and it's surrounding some sclerosis. So osteoarthritis is associated with this syndesmopathic injury. As we move forward, though, some of these injuries are a bit challenging to look at. So this horse blocked, this 6-year-old gelding that blocked to a deep branch to the lateral plantar nerve. As you notice, there's a recurring theme of cross reactivity, and it can be a bit of a challenge to look at it. So when we look at this is a sagittal T1 gradient echo, and this is a dorsal plane fat suppressed image that's going to show our medullary changes with some fluid. So we can see that this area is very irregular along the distal intertarsal joint. The subchondral bone is a little bit sclerotic. There's a mild amount of fluid surrounding this area on the fat suppressed images. And these images are just the transverse images centered at the proximal aspect of the metatarsus, so right here, to show that the suspensory ligament is fairly normal. Just to prove it to you that this is the problem. So this horse injected his hocks, continued on through its work, but the proximal metatarsus was normal. So with that, I'm going to move into the suspensory ligament. As a review, in the anatomic books, it's known as interosseous muscle, and that's important to know because it is truly a muscle. It has muscle and fat fibers in it, and that makes it a bit of a challenge to ultrasound. It's not uniform like our superficial digital flexor tendon and deep digital flexor tendons. In younger horses, that kind of ratio of the normal tendinous fibers to our fat and muscle fibers is maybe potentially a little bit more. So in younger patients, we have more adipose and muscle tissue. And so this is what it looks like at its origin. It is kind of quadrilateral, Valentine shaped. We can see very nicely normal tendon structures. We see all of this structure, very large amount in this horse of muscle and fat. And it's in both lobes of the suspensory ligament. The plantar surface of the metatarsus usually is the primary origin, although there are fibers that extend a little bit more proximal and kind of combine with our long plantar ligament along the fourth tarsal bone. Right, so, and then we also want to realize that there is a check ligament in the hind. I'm pretty sure that when I went through vet school, they told me that thing didn't exist in the hind limb, but it does in almost all horses that I see. There's some vestigial portion of that exists back there. And so that's another one to take a look at. And then here's our medial head of our deep digital flexor tendon superficial. And there's some some fibers of our long plantar ligament coming down, but there's a nice retinaculum that continues around this tarsus area as well. As we think about ultrasound, and this is one of our primary go-tos in looking at the proximal aspect of the metatarsus, this study by Labens in 2009 gave a semi-dismal look at ultrasound of the proximal metatarsus. So 77% sensitivity, again, that's the true positives. But even if it was potentially negative, we have a very low percentage that's truly what's happening. So we missed them, so to speak, when compared to MR. I think these numbers are good to know, but I think we're getting better at identifying lesions in the proximal metatarsus, and that is because of MRI and CT. We're getting much better, and then new techniques that we're looking at these proximal aspect of the metatarsus. And so as we go back and look at these, I think this is a good example of us knowing that our limitations and then trying to push that limitation beyond what was previously published. And some of that comes in the form of what technology we have out there. So most of these ultrasounds now have some form of compound imaging. And this is a nice study looking at a nerve out of a human, looking at compound imaging. And compound imaging is just essentially, very simply put, multiple ultrasound beams in different waves combined into a single image. And what that does for us is it increases our signal and decreases our noise. Signal is the usable information that we have on the image, and that the more signal we have, the better the image, the more confidence we have at looking at those areas. So compound imaging is something that I use very routinely. And so we can see here, no compound imaging going down to here, compound imaging. You can see the difference in the signal that we're looking at this nerve. And this nerve has individual fiber tracts that we're looking at here, right? Here we don't see that so much. So I use that all the time when I'm looking at ultrasound. So compound imaging is a positive. The other thing that I tend to use a lot in the proximal metatarsus, because it has a limited acoustic window, is I use virtual convex. And this is one of the things that will open up my X-ray, my ultrasound beam a little bit more, and at the more distal aspect we can see, some of them call them trapezoidal imaging, but this increases my field of view along this area, and it lets me look in a wider angle and looking at my metatarsus to my metatarsal bones all the way through, looking at the whole aspect of this proximal metatarsus. The other thing to look at is this is being imaged at 18 megahertz. That was not necessarily possible when I first started ultrasounding. Now I routinely look at these horses at 16 and 18 megahertz with newer transducers. They just have the power to get through it. I promise you, this was not a pony. This was a large-sized thoroughbred that I came in and ultrasounded. And so the greater detail we have, the greater detail we have, the more confident we can see in our anatomic areas of imaging and be confident in our diagnosis. The other thing I do often, and that last image was an example of anisotropism, which is really just a fancy way of saying it's angle dependent, right? So anything that has a linear fiber pattern is angle dependent on how it's going to look in my imaging. So if I send in an ultrasound beam, this is kind of simply put, but if I send an ultrasound in, I'm looking for a returning echo from my structure. So if I'm perpendicular to this linear fiber pattern, I'm going to get a nice echo returning, and that's going to be on angle, and we're going to have very echogenic. If I send an ultrasound in off angle, it reflects off this tendon and goes a different path, and that's going to be black. That is, if we read some of the textbooks, that was an inappropriate method of looking at the tendons and ligaments. That is not true. This is the most appropriate method of looking at tendons and ligaments to get the most amount of information we can for looking at those areas. And then when we think about fibrous tissue, this is a disorganized tissue and is not angle dependent, right? So no matter what angle we look at, that's going to be echogenic on our studies. And that is important too, because many times our suspensory ligaments aren't hypoechogenic when we look at them. They don't have hypoechogenic lesions within. They may actually be more echogenic on ultrasound, and that's because there's some fibrous tissue or immature fibrous tissue in this region. So I use those on and off angle images, very nice, on every horse that I look at. So we compared radiographs to our ultrasound. we can look at this. This is a very nice study of several different lesions that occur in the proximal metatarsus. As we look at here, there's this ill-defined increase in opacity, so sclerosis along the proximal plantar aspect of the third metatarsal bone. There's linear mineral sitting right here. I'm going to circle back around to that in a second. And then there's ill-defined areas of lucency, loss of some of our trabeculation in that area. And that's on the DP image. On the lateral image, we can see this large area of sclerosis extending into the medullary cavity, loss of the nice cortical trabecular bone definition. I do like to have both images, and sometimes you need about a 5-degree DMPLO image to get that cortical bone perpendicular, right? I like to have both images because this area right here can be normally a little bit sclerotic, and depending on your angle, the dorsal aspect here can be irregular and project right here, right? And so that summation of the bone can make it a little bit more challenging to interpret and potentially overinterpret. So having both images, lateral and a DP, is important to being very confident in your diagnosis of a proximal suspensory ligament enthesopathy. And these tend to correlate fairly well with our ultrasound and our bone scan in the hind limb anyway. This linear mineralization is important to realize, and this is good to look at along these axial margins, because this is exostosis of the bone. That is a large bone spike that is impinging on our suspensory ligament, right? So looking at this radiograph right here, this bone right here is impinging on our suspensory ligament. So this is a very severe case. This is the same horse, loss of fiber pattern, bony irregularity at the origin. When we ultrasound, this was a technique described by Denoir in 2016 coming from the medial approach. And I start from the chestnut and looking at the chestnut and going distally. So usually about a centimeter or at the base of the chestnut is where I start, and coming in medial. And it's a lot more medial than you expect. You're almost putting the probe perpendicular to the inside of the leg. And that gives us a better acoustic window for looking at our proximal suspensory ligament. So if we look at these lines right here, we're looking at the entire suspensory ligament. Oftentimes we'll miss our superficial, so you have to come around along the plantar aspect. And this is the style that I actually originally learned how to do. And if we look at this, we're missing a quarter or half of our suspensory ligament. And that's actually where a lot of our measurements are when we look at the ultrasound publications. And so 1 to 1.5 was our publication number for what is that. I don't use measurements in my decision-making process. I don't think they're helpful, to be quite honest, to diagnose it, because we know that the normal cross-sectional area of a suspensory ligament is actually 1.8 to 2.2, and that's studies that we've done at CSU very nicely. So the 1 to 1.5 is not a measurement you should use, and half the time we measure things that aren't even appropriate to measure. So I tend to look at more of my radiographic findings to make a diagnosis of an enlarged suspensory ligament. And many times they're not necessarily completely enlarged, they just have dorsal margin tearing. I think that is our more common area that we have of dorsal margin tearing or bone ligament interface as well. So the things that I look at for enlargement per se is whether this is usually a very flat margin along here, if that starts to bulge at all, if I have a loss of space between the dorsal aspect of my suspensory ligament and my bone margin, I think that is enlarged. These ligaments or these vessels right here can become compressed or displaced. That's another thing that I look at, but I don't tend to use measurements that frequently to make a diagnosis. Now I will use it in terms of following a lesion to see what it does over time, but I don't think it's useful to make a diagnosis in the hind suspensory ligament as a decision-making tree. As I look at this area, the suspensory ligament, there's a couple things that are a challenge that we have to deal with. And one is that all of these round structures create distal acoustic shadows, so edge shadows that come down and make this ligament not uniform. And that makes it even more challenging because the ligament itself is not uniform. And then we have these vessels that have through transmission artifacts, so they're brighter below it, right? So that is a bit of a challenge we have to deal with. And we can see that right here. So this is an edge shadow from the vessel. Here's a through transmission, it's brighter than the rest, and here's an edge shadow. That makes it more challenging to identify what we have in terms of uniform fiber pattern coming through there. So it's always a challenge to look at these proximal aspect of the suspensory ligament. Not only that, there's pitfalls, right? If we look at these, it looks for like all the world, there's a core lesion in these suspensory ligaments. These are completely normal suspensory ligaments. And what's happening is we're slightly off angle to our fiber pattern, but we have this periphery of fat and muscle that's echogenic, and essentially we have a hypoechogenic core lesion that is seemingly there. That's not true. That's a falsity. These are normal suspensory ligaments, and some can be very convincingly hypoechogenic in the center as you come along that medial aspect. If you come more along the plantar aspect, that'll go away a little bit, but it will continue to be there. So the one thing I would caution you is that I just don't think core lesions exist in the hind suspensory ligament. One area that is a caveat to that are some of our standard breads, and in the mid-body they can be a little bit more of a core lesion, but even then I think those are rarities. If I had, if somebody told me you have 30 seconds to scan a hind suspensory ligament, this would be the only thing that I did. Non-weight bearing, off and on angle image. I really, to be honest, I'd only do the medial approach because it's convention, and if I didn't include those, I think people would potentially think I'm crazy. I just don't think they're as helpful as they are, and on and off angle non-weight bearing is much more healthy. Or much more helpful to me to diagnose a problem. So I would do non-weight bearing, and I would go on and off angle, and I don't like tipping the leg so much. You'll hear some people just kind of unweight it. I find this much easier and much more helpful to identify lesions in that proximal suspensory ligament in a non-weighted image. So just a farrier sling, put the leg in there. At times I'll just turn sideways, hold the leg, and scan it with the leg in my leg as well, rather than this. But this is probably the most helpful technique that has come along in the last several years to scan a proximal suspensory ligament, and has got us much better at diagnosing lesions in the proximal suspensory ligament. So what does this on and off angle image and non-weight bearing do for us? Well, a couple things. One is it lets us identify the margins of the suspensory ligament much better, and it more closely mimics what we see on frozen transections and MRI. So this correlative imaging is very nice. We can see the same studies over and over again. If we come directly plantar or even on angle, we don't tend to see that as well. The other thing so we come medially, I come medially a little bit, but I usually tend to stay a little bit more plantar. And what that does for me too, as we look at this area, is the bone margins are much more echogenic, and they're angle dependent as well. So if we're not perpendicular to the bone, they're not going to be echogenic, and that is helpful to try to figure out what's happening in the bone margin, because I think especially in some horses, that may be the biggest problem they have, is some enthesopathy or fragmentation along that more proximal plantar aspect. These are all normal horses. This is a study that my counterpart at CSU did, Dr. Barrett. And so as we look, you can come plantar off angle, plantar medial, non-weight bearing on angle. But the biggest things that I see right here, so this is non-weight bearing plantar. I see the bone margin very well. I see this outline of our suspensory ligament very, very nicely. I will always want to come medial and lateral to look into the junction between my splint bones, because those are the areas that those exostoses are going to hide from you, and they can be a bit of a challenge to look at on ultrasound. But I want to come medial and lateral to look down into these areas for areas of pathologic change. Don't be fooled by this little junction here, which is the junction between our fourth and fourth. This is a normal kind of irregularity. The other thing that happens when you come medial is that the bone margin can look irregular, a little bit falsely, right? If we look at this anatomic specimen, the bone margin's a little bit undulant, right? And so that same thing happens when we come medial. We have a little bit of drop off on our ultrasound because we're not perpendicular to it. It looks like for all the world that bone margin is very irregular. If we come more plantar, now our bone margin's a little bit better that we can see. We're more perpendicular to it. We can see it usually has a little bit of a kind of a wide W to it, and then we'll have, if we have any more abnormalities, we'll have these areas of focal bone resorption. The other thing to look at is non-weight bearing in a longitudinal axis, and things just kind of pop out at you a little bit more as well. Like I said, One of the things to think about is we come medial, which has been our approach that we've been doing for a number of years now, but the bone margin isn't well seen all the time when we come to that medial approach. And this is the same horse as we look. This horse can't see the bone margin very well, right? This, we can see the bone margin very nicely. If we come off angle, this is a separate horse, we come off angle, and now we see the margins of the suspensory ligament very nicely. Notice that this horse doesn't have an enlarged suspensory ligament so much. We have nice normal fiber pattern coming from here to here, but along this dorsal margin we have focal bone resorption, and then the tissue around it is slightly echogenic. That in itself is an abnormality, and this horse blocks to this region as well, but we can see this area of fiber disruption along the dorsal aspect and focal bone resorption. So these are the injuries that I tend to see most frequent. And I'm fairly confident that these are injuries because we get to see a lot of these go to MR, and we get to see them back in our ultrasound as well. In fact, so much more now that we're confident these things are coming, we're ultrasounding ourselves out of MR, and as a radiologist, I kind of like MR. So, but if we get MRs and you get horses that go to MR, that's only half the job. The other half is following up with an ultrasound and making sure you can find the lesion that was found on MRI if it has a soft tissue injury. I think that is part of the game that we need to be good at, is following these horses up after MR or after CT and going back and looking at these proximal suspensory ligaments, following them then after we treat them and knowing what they look like after treatment of any kind. Now the other thing we look at is the longitudinal, right? So this is a horse, a warm blood horse that had blocked the proximal metatarsus, the 3-day eventer. We look at this region right here, right? We've noticed some irregularity along this longitudinal fashion here, and now we do this in non-weight bearing. We see this huge defect in the proximal aspect of the third metatarsal bone. And so it's important again to look at these in non-weight bearing, and it lets us manipulate those tissues around, get rid of some of our shadows that we tend to see, and look at these, the bone margin and the dorsal aspect of the suspensory ligament much clearer. Like I said, a majority of the tendon or the ligamentous lesions that I see are mostly hyperechogenic by the time they come to me. So they're a little bit more in the chronic stage. And this is an 8-year-old Tennessee walking horse that came in for a chronic hindland lameness. And we can see that if we go off angle, right here, this ligament is a little bit enlarged, so it's rounded here. The vessels are slightly displaced, more plantar. And then along this dorsal margin, we have this well-demarcated area of hyperechogenicity. If we just did this on angle, we would probably miss that lesion, right? And so this is the more significant. There's a little bit of bone irregularity here. We start to lose some of our fat muscle definition here, enlarged, but this is a large lesion in the dorsal aspect of our suspensory ligament. So the dorsal aspect is probably our more common. We can also have injuries along our plantar aspect. This is a 6-year-old quarter horse gelding, went to MR. We got to follow it up with some ultrasound. We see this nice triangular defect that's hyper intense on our transverse images at the level of the proximal metatarsus. So triangular tear within the suspensory ligament, corresponding image. So this is a more of acute tear, so hypoechogenic in on-angle imaging, and that would indicate some cellular infiltrate or fiber disruption, hemorrhage, that kind of stuff within our ligament itself. As we think about then, we can have more diffuse injury, and this is kind of a mid-body lesion. We want to think about what our normal fat to muscle ratio is going to be in our our proximal aspect and our mid aspect, right? So in the proximal aspect, it's more of a teardrop shape, each lobe, Valentine shape, and then as we move into the mid aspect, it's more curvilinear, and this is a transection right at the same level, curvilinear fat and muscle, and then here it has a little bit of a lightning bolt kind of appearance to it. And now if we look at this horse, we've lost all of the normal architecture in the mid aspect of the suspensory ligament, both on and off angle, and it's enlarged and rounded, and this is the corresponding MR. So we've lost all of that architecture. So diffuse injury in the proximal or in the mid aspect of the suspensory ligament. So knowing what that distribution is of fat and muscle is important to try to look at. And then We touched on a little bit, there's a proximal bundle that extends all the way up into the fourth tarsal bone, is confluent with our long plantar ligament. And so this is a cross section roughly the same level. This is our proximal bundle coming up into our fourth tarsal bone, long plantar ligament. This is the MR, so this is our proximal bundle, and this is the ultrasound. So superficial, deep, and then here is our proximal bundle sitting right here. And that can be injured, usually not by itself. We did a nice study, a retrospective study looking at 100 horses, and it's very nicely correlated with severity of lesion in the main body. So, but that can be one area to think about if they have a severe lesion, they become refractory to that particular location. Maybe you're not necessarily treating a more proximal portion that can be injured as well. And so this is a horse, we can see this marked enlargement of the proximal bundle coming up. This is the corresponding ultrasound as well. So as we look at that particular area, some horses can have a primary or a more severe lesion in the proximal aspect of the metatarsus, although almost, at least in the horses we said, 100% of them had an injury to the main body of it. So not just this was injured, but this horse had probably the most severe injury that we saw, which is this split tear within the proximal aspect, and we can see that right here coming in. So this is part of the ligament, this is part of the ligament, and then there's this nice split tear between the ligament itself. So this horse was a primary injury to that, but also had injury to the proximal aspect of it in the third metatarsal area. And then don't forget, we don't want to get focused just on our suspensory ligament. We also want to focus a little bit more on the surrounding tissues. So again, this horse blocked to the proximal aspect of the metatarsus, but as we look at the superficial, the deep, and then we have this huge structure sitting right here and here, this horse has a torn check ligament. While rare, these can be quite significantly lame, toe-touching lame, and be a marked source of lameness. The proximal aspect of the suspensory ligament is fairly normal. I'd like to just conclude with the study that I was talking about. And so 125 limbs of 103 horses were looked at on MRI. An overall pathologic change, we had 48% were in the tarsus, 39% were in the proximal suspensory ligament. We had 73 of those, we had known blocking patterns, so we were able to call the vet and they knew exactly what they blocked. And they blocked to the deep branch. 73 of them blocked to the deep branch. 44% of those had the greatest osseous changes in the metatarsus, while 46% of them had the greatest imaging changes in the tarsus, right? So just realize that there's a lot of overlap in the blocking pattern, and imaging wise, we can have more significant lesions in the tarsus even though they block to the deep branch. So a careful study of that area and potentially thinking about them as treating them as a region, both imaging wise and as a treatment option is potentially an approach that might get us more successful in getting some of these horses back to work. Have any questions you guys might have? Yeah.
So, in your discussion of the lesions in the tarsus, you showed your radiographs, your area of interest, and then you said, and then it blocked to so-and-so. So have you already done perineural blocks to isolate the lameness to the tarsus, to the hock, and then you're just coming back and using those other blocks for refinement, or?
Yeah, so the question is, so we have imaging, and then how often do we go back and do blocks afterwards to prove our point?
The question is how often we block them before you?
They're almost always blocked before, and then blocked after at times if there's question, right? So almost always block before, and then go back and block afterwards if there's a question. And I think that is a good point, is going back, can we refine these, prove our point a little bit better, make sure we're getting the correct diagnosis once we have an imaging diagnosis. Does that answer your question?
So you're just confirming your diagnosis from your images with your refinement?
Yep, yeah. And I think that happens less so with ultrasound and radiographs that I think about it, but is probably a little bit more common with some of our advanced imaging. So MRI, we can have multiple lesions, and some of those lesions can be ambiguous in their clinical relevance. They might have a similar lesion on the other side kind of thing if we do bilateral images. So I think going back and blocking them to try to prove whatever point we can is a good methodology to try to figure out a little bit more about clinical relevance. Any questions?
I think that's a very important point. A lot of people send horses in for neurectomy, and without MRI, you really don't know what the response is going to be. You still may be able to manage the horses effectively with the neurectomy, but you're also going to have some of the funding problems as well. Obviously, it's expensive because of very current study.
Thank you.